being with us.
No, it's always my pleasure. I had a great time with you all in Tumkur.
Yeah, please, sir.
Sir, shall we start, sir?
Yeah, please, sir. Please go ahead, sir.
Okay, sir. Start.
ನಮಸ್ಕಾರ ವೀರಭದ್ರಯ್ಯ ಅವ್ರಿಗೆ.
Namaste, sir. Utre sir is son-in-law of Tumkuru. I'm very proud to have him with us. So let us listen to him. He's a very good orator and very good senior member of IMA. And he was mentor in Maharashtra Medical Council. And so many adds to him. He's a very good friend of us also. So we welcome you, sir.
Thank you very much, sir.
Madam, you can go ahead with the IMA prayer.
ನಮಸ್ತೆ ಎಲ್ಲರಿಗೂ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ವಂದನೆಗಳು.
I request our chairman Pawan Kumar to welcome.
Thank you very much, madam, for the IMA prayer. Being chairman of the public health subcommittee, I would like to welcome everyone for today's evening CME. First of all, I would like to welcome our Karnataka State branch President Dr. Veerabhadraya sir for today's CME, and Dr. Suri Raju, Secretary Karnataka State Branch. Today, due to his prior commitment, he couldn't attend it, but I would like to welcome him. And I would also like to welcome Dr. Harish, who is President-elect of Karnataka State Branch for today's CME. And our today's distinguished guest speaker, Professor Dr. Shivkumar Utture. I would like to welcome him. Welcome, sir, for today's CME. And our senior most Professor Dr. Shivkumar Kumbar, who is the moderator of today's CME. I would like to welcome you, sir. And our other seniors, Dr. Rajendra Prasad, sir, who is instrumental in conducting all the CMEs. I would like to welcome you, sir. And our senior past Vice President, Women Vice President, Dr. Anuradha Parmesh, I would like to welcome you, madam. And Dr. Vinaya Srinivas, who is a very active member of our Public Health Committee. I would like to welcome you, madam. And I would like to welcome all other seniors like past presidents, vice presidents, and other members, IMA members, who all have joined for today's meeting. And we would like to begin with our Karnataka State President Veerabhadraya sir inaugurating our CME. Over to you, sir.
Thank you, sir. I have introduced him, so you can go ahead with the webinar, sir.
Yeah. I think our today's guest speaker introduction will be given by Dr. Vinaya Srinivas. Over to you, madam. Please introduce your speaker.
Thank you, sir. I'm really honored to introduce such a great resource person, Dr. Shivkumar Utture, today. I'm really honored. Sir is a prominent medical leader and general surgeon based in Mumbai. Sir has completed his MBBS and MS from Lokmanya Tilak Municipal Medical College, Sion, Mumbai. He is widely recognized for his leadership in the top medical regularity and professional bodies in India. He has served as member of National Medical Council. Currently, he serves as National Vice President of India, Vice President of IMA. He is the former President of Maharashtra Medical Council. He is a vocal advocate for medical ethics and communication. During COVID-19 pandemic, he has played a crucial role in framing guidelines for telephonic consultations. He has bagged many major awards, to name a few here. He has been awarded with BBMG Mahatma Gandhi Award in the year 2020, which was conferred at British Parliament, London. He has been awarded with IMA National Corona Warrior Award in the year 2020. He has also got A.K.N. Sinha National Award for his distinguished service in medical education. He has been awarded with Lifetime Achievement Award in the year 2015, awarded by IMA Mumbai. He's also got Excellence in Ideas.
Awards, sir.
Yeah, many awards, and I'm naming a very few. He has been recognized as a top medical teacher in the Government Medical College. Now also he is an honorary professor working in various hospitals, St. George's Hospital, Fortis Hospital, and Sushruta Hospital. We are really proud and honored to have you as a resource person for this session, sir. Thank you for giving me an opportunity to introduce, sir. Over to you, sir.
Thank you, Dr. Vinaya, madam.
Thank you, madam. I think we'll
doesn't need any introduction. I will straight away go with, over to Dr. Shivkumar Kumbar.
Yeah. Good evening, President, Dr. Virabhadraya, Dr. Suriraj in absentia, and Dr. Anuradha, Dr. Pawan, and Dr. Kanchi. I'm really honored. And Dr. Harish too.
Dr. Harish, sir. President-elect.
Yeah.
Dr. Harish.
Yeah, I'm there. Yes, also. Yeah. And all the members of IMA KSB. I'm really honored to be the moderator for the very important session, which is going to be spoken by Dr. Shivkumar Utre, and who is a well-known medical legal expert. And I have been associated with him since almost a decade, I would say. And they called me as an honorary member of medical legal cell of Maharashtra also. And he's an excellent orator. And as an anesthesiologist and a surgeon, we do come across a lot many things, a lot many hurdles, how exactly consent should be taken. And it's a very, very difficult topic, and I'm very much sure he will make it a very short and sweet and very understandable. And consent is a requirement of medical practice and not just a procedural formality. Getting mere signature on a form is not at all consent. It's a null and void. And often medical professionals either ignore or are ignorant of this requirement of valid consent, and most of the times 60 to 70% of the medical legal issues they land in problem only just because they lapse the consent. So let us hear from him, and I'm very much sure that there may be a lot of questions. Dr. Utre and myself will be able to answer as much as possible. Thank you. Over to you, Dr. Utre, sir.
Yeah, thank you, Dr. Kumbar, sir. I'll just yeah, can you see my slide?
Not yet, sir.
Yeah, now can you see it?
Yes, sir.
Yeah, okay.
Let's do slide share. Yeah. So,
Yes.
respected President Sir, Dr. Virabhadraya, Secretary Suri Raju, Dr. Harish, then Dr. Pawan Kumar, Dr. Rajendra Prasad, Dr. Kumbar, Dr. Kanchi, Anuradha Madam, Dr. Mahesh, Dr. Vinaya, all other office bearers and all senior leaders of IMA Karnataka. At the outset, let me thank you for having invited me. Karnataka, as you know, is my original home, though I'm settled here in Mumbai. So it's always a pleasure being over there. And I have had a great time just a few weeks back where, I have enjoyed your hospitality at Tumkuru. So let us come directly to the subject of informed consent, one of the most important aspects as far as complaints are concerned against any registered medical practitioner. So in the council for almost 10 years since I was there in the council, let me tell you, more than 50% of the cases are purely because of not having taken a proper consent from the patient. Unfortunately, during our days of residency or even post residency, we were never taught the importance of this consent, because at that time I still remember that consent was a very simple thing where we used to write preoperatively that I'm willing for any procedure, any surgery under any anesthesia, and that was all. That one line consent was there. But things have changed nowadays. So let us see exactly what we are supposed to do as far as the modern era is concerned. So basically, you have to understand that consent should always be free and voluntary. This is the first tenet of any consent taking whenever we are doing any medical procedures. And this patient is supposed to be voluntarily giving you this consent without putting any pressure on him. Then if you see consent, it has not been properly defined in any of our medical books or in our code of ethics, may it be the state code ethics or the National Medical Commission ethics, right? What mention we see in consent is in the Indian Contract Act of 1872. And basically what it defines is that two or more persons are said to consent when they agree upon the same thing in the same sense. This is the broad meaning of, legally how consent has been defined in India. But this consent becomes so important because the defense against any civil or criminal liability by a doctor purely depends on how he takes this consent from the patient. And many a times, even when when our counsel or a lawyer is presenting our case in any court, may it be the criminal court or it may be under tort, that means a civil court, it is a consent which is supposed to be helping you out or helping your defense to a great extent. So let us see exactly how we should go about so that we are never caught on the wrong foot in the future as far as this consent is concerned. So what does the law say as far as medical consent is concerned? And why is this importance of medical consent? In the past, doctors were, almost like gods on a pedestal. So whatever we used to say, the patients used to accept that, the relatives used to accept that. But unfortunately, gone are those days because the doctor-patient relationship has completely eroded. And today we have to, as per how the times change, we are also supposed to be changing as how we manage these patients. And why has this change come? This change has come purely because of advancement in the technology in our day-to-day practice. So technology, not what we are using, but I think technology more of what the patients are using. Because it has become so easy for the patients to become aware of their rights because of this technology. And at the click of a button, they can go onto any of these code of ethics sites and find out exactly what are their rights. And that has completely changed the doctor-patient relationship. Whenever I give a talk on doctor-patient relationship, we say that it was first paternalistic. That means we used to say something and that used to be just, the patient used to just nod and accept what we say. But today it has become mutual. So it is mutualistic. That means it has both the patient and the doctors on the same level as far as consent is concerned. So more and more patients have become aware of their rights, and they know today that they have got the right to choose the treatment of their choice. Not only that, they have got a right to choose the physician of their choice. So they may come to you and then you may, get all the investigations done and, look after the patient, tell him everything. But ultimately, the patient can choose where he wants to go. That you have to remember. You have no control on that. So the choice of the treatment and choice of the physician both lie with the patient. So when are we supposed to, and from whom are we supposed to take the consent? Let us look legally how things are today. So remember, the minimum age of consent is 12 years old. But remember, that is not consent. The legal term used is the assent. That means whenever you are examining the patient, if the patient is 12 years and above, he can give you consent for examination only. Right? But if you are going to do any procedure on that patient or any major diagnostic or surgery or therapeutic procedure, then the patient has to be minimum 18 years old to give proper consent. So what about this age group between 12 and 18? So age group between 12 and 18 for examination, they can give you a consent. But for any procedure, you require to take the consent of their parents or surrogate parents, whatever they are. Below the age of 12 years, even to examine the patient, you are supposed to take an oral consent from the parents. So you cannot examine a patient without their oral consent. Of course, in India, we are lucky because all children are invariably, they are accompanied by their parents. So it becomes very easy to do that. And hence we don't much bother as far as the consent is taken for examining the patient. Not only the patient should be 18 years of age, but the patient should be mentally sound to give you consent. That means he has to understand what you are saying. And that understanding should be without any fear or threat or any false conception. So that onus lies with us doctors today legally. Then the patient should not be intoxicated and sedated. A very important aspect. Because I'll come in the further slides, especially preoperative patients and everything, when we take a consent, when we are supposed to take a consent, all that in details I will talk. That is because invariably the patient's preoperative may be sedated or intraoperative also may be sedated, and we really cannot take a consent in those circumstances. So, incomplete information which is given to the patient can be taken as commission than misconceptions of omission. So, it is an act of breach of commission and not of omission. So, commission, as you know, becomes much more, as far as the law is concerned, it is at a higher level than what is an act of omission is concerned. So where do we require to take consent from a patient? If you see the first 4 or 5 points which I have given you, almost any and everything that we do in the management of a patient requires some form of consent. Which form of consent is required? I will come to that in the further slides. But remember, right from examining the patient to doing anything, any procedure, small, minor or major procedure or surgery, or for that matter, organ transplantation, blood donation, infusion, or taking an autopsy, biopsy, taking even a needle biopsy, you require to take the consent of this patient. And if the medical practitioner attempts to treat a person without valid consent, then he will be liable for not only under the civil law, but also under the criminal law. Understand that. If something goes wrong and you have taken a valid consent, you can be liable under the tort. Tort means that is the civil law. Of course, unless there is death or anything like that, there is gross negligence, then it may go for a criminal law. But if you have not taken consent, you can be liable under both the laws. So that is an important aspect. And the difference between civil law and criminal law is that in civil law, the patient is supposed to prove that what you have done is wrong. So the onus lies with the patient. But if a criminal case is accepted by the court, the onus is on the doctor to prove that he has not done anything negligent. So that is a huge difference of how these cases are held by the courts. So another aspect you have to understand is that patient has a right to refuse a treatment even if that said treatment will save his life. So you cannot force upon the patient to give consent and do any procedure, even if you feel that if I don't do this, the patient is going to lose his life. No. The onus is on the patient. The patient has got a right to refuse it. And this last sentence is the most important, that any physical contact or application of force without prior permission is assault and battery. So remember, in today's world, even if you hug someone or put your arms around someone's shoulder, especially if it is of the opposite sex, that can be taken that without permission of that patient, you are forcing yourself on that patient, and hence it goes under criminal aspect, that is assault and battery. So consent becomes so important, and unfortunately, as I said, we are never taught much about consent in our formative days. So we saw where consent is required. Let us see where consent is not required to be taken by any doctor. So if a medical legal case has been brought by a police in a criminal procedure court, you can examine the patient without his consent. No need to take consent of this patient. But he has to be brought by the police. And remember, the last line is the most important, that the written request by the police officer has to be there. Without that, you should ideally not touch a patient at all, even if the police accompanies him. You know, invariably, these police are those ones who are criminals, whom they bring to you, number one, where they're supposed to compulsorily take a medical, examination of the patient, that he has not been assaulted, he has not been, in the jail, he has not been, third degree has not been given to that patient. So you do this only if he is giving it to you in writing, otherwise do not touch this patient. Insurance policy is another thing, where you examine the patient, when the insurance company sends to you, because the patient has already consented when in that contract which he has had with the insurance company. Whenever all of us have taken insurance, we don't read through those insurance papers. It's a thick booklet where we sign on every page. And one of those pages, when you sign, you have consented to be examined if the insurance company requires you to go to a doctor. Then, of course, in the interest of the community, especially in notifiable diseases, you do not require consent, because here the government, under the law, has given you the right to inform the government whenever it is a notifiable disease. So, classical example today is tuberculosis. So, you do not require the consent of the patient to inform the government authorities that this is a case of tuberculosis. So like that, there are many diseases which is a compulsion for you to inform, because they come under the notified category. And then, of course, under a court order where the court sends it to you, but again, the court sends you a written requisition to examine this patient and give your expert advice as far as that patient is concerned. So these are the areas where you may not require a direct consent of the patient for doing, especially for examining these patients. So what are the different types of consents which are there? As I told right in the beginning, that as far as management is concerned, right from when the patient walks into your clinic till you have done the procedure, there are different types of consents which you have to take depending on what you are treating. So they can be implied consent, there can be express consent, which is also called in legal terms as true consent, and which till date we were following in India whenever we were doing any procedures. So this could be either oral or written. And then, of course, the informed consent, which is today's topic, which in today's world, it's a compulsion for you to take informed consent. So what do you mean by implied consent? The very fact that the patient enters your clinic, it implies that the patient is willing or is consenting you to examine him and give primary treatment. So when primary treatment, it could be medications, it could be injections, whatever. You don't require any special consent for those. So implied consent is only for routine examinations and routine treatment of that patient. But remember, if you are examining some intimate, part of the body, the minimum you have to do is you have to take an oral consent from that patient. If you try to examine without taking oral consent, so this could be either breast examination in a female, or a vaginal examination, or a PR examination, whatever it is. So you have to explain to the patient what you are doing, and this oral consent has to be taken. And if you feel that there is going to be any slightest chance of complication, remember, you have to go in for what is called as the express consent. So express consent can be either in the oral form or in the writing form. So when do you take express consent in the oral form? As I said, when you are doing examination of intimate parts of the body, or you are doing something like putting in a Ryle's tube, putting in a catheter, taking an angio. So all these require you to take an oral consent. And it is always good to take this oral consent when a third person is present over there, especially if it is a relative, it is the best thing. And not only that, it is always a good habit and good practice that you note down that the oral consent has been taken from this patient before you have done that procedure. On the paper, it could be OPD paper or endo paper or whatever it is. Just note down that the patient has been explained that I am going to put a urinary catheter for this patient, and he has consented orally. You don't require to take any written consent for that. A written consent, again, is taken whenever you are doing a procedure beyond all these routines what I have told. So if you are going to do, say, a simple thing like an IND or CLW suturing or anything, you cannot take an oral consent only. So you have to go for a written consent. Again, it is always better to take it in front of a third party, and you take the signature of that third party also. Now, why do you take the signature? It is just to say that that third party is attesting the signature of the patient. The third party does not require to know the details of the procedure that you are doing. So this is for safety. Then it should be in the language of the patient, or at least it should be explained to the patient in his language. And one of the lines, as you know, common line that we put, that the patient has been explained in the language that he understands, and he has consented it, and he is signing that paper. So any invasive diagnostic or therapeutic procedure or any medico-legal examination, like the patient has come to you after a fall or a CLW or a IW, incised wound or anything, you have to take a written consent. But as I said, in today's era, expressed written consent is almost given up, and we go for what is known as an informed consent, which is the most important aspect and the topic of today's talk. So how should an informed consent be? So it should be a voluntary acceptance after fully understanding by a competent person of what you are going to do, that means what management you are going to do. After you have disclosed the proposed plan, the risks and benefit of that management, and if there are any alternative approaches over here. And it should be free from coercion or manipulation. See, every word that I have used over here has got some legal connotations. And out of this, the thing that we generally omit or we forget to tell the patient, we tell them that you require this surgery or this procedure or whatever it is, but we forget to tell them what is the risk and benefits. And what is an alternative approach is also there. Because as I said right in the beginning, the patient has got a right to choose the management. So he may choose something which is non-medical, I mean non-surgical or anything if he's scared of surgery, and you cannot force it on that patient. And to do all this, there are a few components that go as far as these consent is concerned. Number one and most important, that the patient should have the mental capacity to enter this contract. As I said, consent comes under the act of contract. So he should be full mental capacity. Complete information has to be provided. That means you have to talk to the patient in his language without any technical terms. Don't go into statistical data which the patients do not understand. And you have to invite them to ask questions. Then there has to be a voluntary acceptance of the procedure by the patient. That is the right of the patient. And that consent should be person and procedure specific. When you say person specific, I'll come to the what exactly that means afterwards. But remember that the patient's name should be the first thing that should be written, that I so and so consent. You cannot have a blank form over there. Not only that, the type of procedure or the type of whatever surgery you are doing has to be mentioned over there on the consent form. And this consent form should be signed. Now, in between, because of, in one of the CPA cases, a big halabulla was done that pre-printed forms are not allowed. Let me tell you, that is not the case. It was projected wrongly. You can have a printed form, but that printed form has to have blank spaces for putting up all these, the name of the patient, the proposed plan of treatment, the risks and benefits, alternative approaches. So the printed form should have all these columns where you can fill this up actually depending on the patient and depending on the treatment modality. And the last part, video recording. That is the best thing that you can do as far as consent is concerned, because there are many things which we talk, but we do not put it down in writing when we are taking consent. And especially if a patient is a complicated case or the patient is an ICU, remember the daily progress, you are supposed to be talking with the relatives as far as that patient is concerned. And the best way is to take a video consent. But remember, whenever you are taking a video consent, your first sentence should be that I am videographing this consent, and do you consent for getting this videography done? And the patient or the relative should say yes, and then only you can continue with the videograph. So there are a few doctrines which are there as far as consents are concerned. So doctrine of full disclosure, I have already told you that, where the alternative treatment, if it is there, the possible risks which are there, the benefits of that procedure, everything in details you are supposed to tell them. Mental capacity, physical condition of the patient should be such that he can give that consent. The after effects of whatever is, the procedure going to be has to be explained to the consent. And the therapeutic privilege of a doctor in an exception to the professional secrecy. I will come to that in the next slides. So consent should not, remember, consent should not be there only in a surgical procedure or for the surgeons, but even simple thing. I have shown you that cartoon below. In a pediatric case, remember, patients are very, very particular as far as the treatment of their children are concerned. And today they read everything online or whatever literature has been given to them and they come to you. So you better be very careful that you tell them, see, any and every medicine can have some risk. You don't require to tell all the risks possible, but the common, risks which are there that the patient will be having for taking that medications has to be told to that patient. Because then the patient has got a right to continue or not to continue with that treatment. So there are some exceptions also which are there under the law you can have. That is doctrine of therapeutic procedure. So this is a therapeutic privilege. As a doctor, you have this privilege where if you feel that the patient will not understand the complexity of whatever treatment you are giving him, or sometimes the patient itself, which is very common in India, where they say, I am not interested in knowing all the details. You do what is the best for me. But in such circumstances, it is always a good habit to explain the details to a family member, even if you don't explain the details to the patient before taking the signature. Then in an emergency, you as a doctor are allowed to treat a patient if there is a chance that the patient may lose his life. So limb saving and life saving, if it is there in an emergency, even if the patient is alone, then you have got a right to do something without taking the actual consent of that patient. But here also sometimes, especially if you have got a colleague with you, and this especially the gynecologist will understand, that a colleague should also sign that this procedure was required by the patient to save his life or save his limb. So that is always, legally you are protected if a colleague also signs that this treatment that you are giving is required. Then, of course, proxy or surrogate consent is there. I will come to that in the future slide. What do you mean by proxy or surrogate consent? So proxy or surrogate consent is where we call it the loco-parent consent. That means in an emergency. So simple example to give you, that a boy or girl or a student is there in school and he has a fall or he has, convulsions or whatever, and he's rushed by the school teacher to your clinic. Now here the school teacher acts like a surrogate parent, and the school teacher has got a right to sign on that consent form, and you can go ahead with the treatment. So this is called surrogate. Till the actual parents of the patients come, the teacher becomes a surrogate parent. In an incompetent patient who is, say, delirious, unconscious, senile, or psychotic, and if it is an emergency, you can go ahead without treatment. Or if suppose a patient has a fall on the road and he is brought by the police or anything, the consent of that police can also be taken. Therapeutic privilege, I have told you already, when you have got a right to do that. But the full information to a competent relative must be given for you to be on the safe side as far as law is concerned. Now, what are the essential principles under the law? A few cases I will, these are classical cases which are there, where many of, lectures you must have heard about that. So a doctor must take the consent of the patient before commencing a treatment and procedure. And this was a classical, this case where invariably when a patient is for surgery, we admit him in the morning, and just before his surgery, the nurse goes with the consent form to him and he signs that consent form. Remember, the patient can in the court of law say that I was not mentally very stable because I was quite apprehensive because I was to undergo a surgery, and I did not understand the consent that was taken from me. So never rush a patient into giving consent. I always tell my students that it is always better to give the consent form when the patient comes to you to fix the surgery. So the day before or whatever it is, let the patient take the consent form at home, let him read through the consent form, and then sign it and bring it to the hospital when he gets admitted for that surgery. That is the best way to do it. Not when the patient is being wheeled into the OT. That is not the time for you to take the consent. Consent has to be compulsorily taken from the patient. You cannot take a consent from someone else, the relatives or whatever. So if he's 18 years old, he is competent, mentally stable, then the patient's consent is a must. You may or may not take the relative's consent. Under the law, only the patient's consent is legally binding. But as I said, it is always better to take the consent of the relatives, so that if God forbid some mishap happens afterwards, you have someone to tell you or tell the court that yes, the doctor has taken all adequate precautions. He has taken the consent properly after telling all the details. Then, of course, competence and capacity is there. I have told you the years where the consent is compulsory and what type of consent is there. Consent should be free and voluntary. It should be informed. We have seen what exactly the informed consent means. So it has to be informed. All the details of the management has to be informed to the patient. Blanket consent is absolutely not valid. I'm specifying this because senior members were used to that, as I said, that we used to write, I am willing for any surgery under any anesthesia, and the patient used to sign. Those were the days, at least when I was a resident. That is no more, valid as far as the legal problem is concerned you may face tomorrow. Fresh consent should be taken for any repeat procedure. So suppose a simple case you are taking, say an IND of a patient, and you do an IND, you have taken a proper consent. But after 1 hour, 2 hours or so, the patient starts bleeding from that wound. You cannot do the next procedure without taking the next consent. So if it's a repeat procedure, a consent is a must. For all my anesthetist friends, invariably they never see or go into the details of the consent form. Remember, the anesthesia consent is completely different from what a surgeon takes his consent. So ideally, there should be a separate anesthesia consent form which should be there if you're doing any surgical procedures. And this is for the safety of the anesthetist I'm saying over here. Or the anesthetist himself should write down that I have spoken to the patient, I have told him what type of anesthesia he is going to get, I have told him what could be the risk or common risk factors, and the patient has consented. So there should be a different anesthesia consent form. And all this should be well documented. Why I'm saying well documented, many a times cases which have come to us in the council, the consent forms are invariably taken by the sisters in our clinics. And because of the work pressure and everything, the sisters take a blank consent form to the patient, which is just the printing material is there, but without filling any of the columns, they take up consent from that patient. And then they forget it because of the work pressure. I have seen consent forms which have come to me in the council where even the name of forget the procedure, the name of the patient is also not written on that form. It is kept blank. So for God's sake, don't do that. And I always tell my colleagues, you should be the last person to sign that consent form before you go to the theater to operate on this patient. Two things that does. Number one, that you see that the consent form is completely filled. And the second thing is, as an operating surgeon, you are supposed to be telling the patients all the details. So tomorrow when the court asks you, you said, yes, I have told them because my signature is there on that consent form. So that saves you tomorrow in the court of law also. Remember, the patient, even if he has consented before the procedure, he can say, I don't want to undergo this procedure. That is the right of the patient and you cannot force that procedure on that patient. Even if you are in between the procedure and the patient says, I don't want to undergo this procedure. Again, if you stop that procedure and it is not going to, physically harm that patient, that procedure has to be stopped. This is very, very clear as far as the law is concerned. So the patient has got a right to withdraw his consent if he has given or refuse a treatment even if it is life-saving procedure. Witness consents are legally more dependable. As I said, legally, you do not require to take the second signature Other than the patient signature is a compulsion, the second signature of the relative. If you take, you legally are on a safer ground. So take the signature of the relatives also. Another aspect is consent for blood transfusion. Remember, blood transfusion consent is a must, which we many a times forget to take. Not only that, for repeat transfusions, you require to take repeat consent. So you may give blood today after the procedure or during the procedure. Then the next day, because the hemoglobin has not gone up, you may give another blood transfusion. Remember, when you give that second bottle, again, you are supposed to take a consent. So don't forget to do that. Another important aspect, and this is what I tell to all my colleagues, surgical colleagues, you do something in a patient which is something unique or something difficult, and you have video recorded that for educational purpose, and we put it up especially on the WhatsApp media. Remember, if any photograph or any videograph which identifies that patient, you are in a soup if you have not taken prior consent from that patient. Just recently, you must have heard that it had come in the papers also, where the face of the patient was not seen, but the patient recognized that this was the procedure by the date, the place which was videographed, that particular OT and particular clinic, and the time that was there on that videograph. The patient recognized that this was my videograph taken during my procedure, and he has sued that doctor, and that doctor has been fined. So in any case, if it is the patient's identity is revealed directly or indirectly, you will be in problem unless you have taken a consent from that patient. And let me tell you, our Indian patients are so good that if you explain to them that I'm taking this photo or video, they will always consent. Rarely ever I have seen where the patient has said no. So take the consent of that patient. As I have said, the consent should be procedure specific. And this is a very, very classical case of Samira Kohli versus Prabha Manchanda, where the patient was being operated. The doctor found that beyond what he had taken consent from that patient, the patient had some disease which required an extended procedure. He came outside, explained to her mother, and took the consent of her mother, and he went inside and continued with that extended procedure. Post-operatively, when the patient came to know that this was done, the patient sued that doctor because, as I said, the primary consent of the patient is a must. And the doctor was in problem. I know sometimes it feels it is so stupid and foolish that if I am operating on the patient in the abdomen, I find some other disease. Should I or should not operate on that disease? Because you're doing it for the good of that patient. But what does the law say? No, unless it is a life-saving procedure you are doing, you are supposed to close up the patient, bring the patient out of the anesthesia, explain to that patient that this also is a problem that you have got and I require to take your consent to operate on you, and do the second surgery. So you feel this is a foolish thing, but remember, you are supposed to do it legally. And this was what the doctor landed up with problem. So it should be procedure specific. So if I'm doing a gallbladder in a patient, and after I open an abdomen, I feel that even the appendix is infected, I cannot go ahead and do an appendicectomy. No. If that is not going to be life-threatening, you close the patient, bring him out, take a consent of the patient, and at a later date, you do the appendicectomy. Then consent should be taken, as I said, pre-operatively, not during when the procedure is going on. So if you, I repeat, if you find that there is some other problem, on the table also, I cannot take the consent of the patient. I'm doing something under spinal anesthesia. Patient is awake. This is not acceptable at all under the law. And this is another famous case of Dr. Janki Kumar, where the patient was under anesthesia, that means a spinal anesthesia, and they took a consent for a further procedure in that patient, which was not accepted by the court. Then, of course, I go one step further in today's world. Telemedicine has become very common, and majority of us are doing telemedicine. Do you require consent in telemedicine? Remember, in telemedicine, we never do any procedures. Okay, it is just consultation and giving the treatment. But yes, there are two types of consents which are there in telemedicine, that is implied consent and explicit consent, which has been put down in that telemedicine rules and regulations. Implied consent is when the patient himself has come to you on telemedicine for consultation. The patient, just like how we saw, when he walks into your clinic, it is implied that he's allowing you to examine the patient and give treatment. So here also it is implied that he is giving you the permission to treat and give medicine, right? But in telemedicine, there is a third person who is also sometimes allowed to interact, and that is a health worker, a RMP, a caregiver who initiates the telemedicine. And in such circumstances, online, the first thing you're supposed to do is take this explicit consent from the patient that the patient is willing for that third person to be over there. This is especially important for my psychiatrist friends when they are doing telemedicine. You cannot have a third person over there in your clinic or at the residence of that patient when you are doing teleconsultation, unless you have taken permission and consent online from the patient. Number two, whenever you are giving the prescription, remember this. This has nothing to do with consent, but since I'm talking about telemedicine, your prescription should never be in the Word format. Invariably, I have seen majority of the doctors on WhatsApp, they send the prescription to the patient. No, that is not allowed. Right? Your prescription should always be a scanned copy, a digital copy, and it should be a signed prescription or a e-prescription if you are sending it online on email. Why? Because patients can misuse this prescription afterwards, especially if it is in the Word format. Or the words can be changed when they go to the chemist. So don't ever send any prescription in the Word format. Then nowadays, and this is very common in Western countries, it has not come in a big way in India today, you can send the prescription directly to the pharmacist. And the patient only goes to the pharmacist and collects the medicine. But remember, if you are doing this, then you require to take explicit consent of the patient that his medicines you are sending directly to the pharmacist, who's a third person. And only if he gives consent, you are supposed to transmit it to the pharmacist directly. So this is as far as the telemedicine practice is concerned, where also consent is very important. So what can we do to improve our informed consent? Simplify the language in which you talk to the patient. Make sure that the patient understands. Ask the patients or encourage the patients to ask you questions. Talk in the language in which the patient is, familiar with. And if there is an interpreter, you take the signature of the interpreter also, because there may be a patient who knows a language which you do not know, and it is the interpreter in between who talks. You talk in English, and then the interpreter say Telugu or this, which I don't understand. The patient, he talks to the patient. So at that time, the interpreter's name and his signature should be there, if he is translating what you say. Signing and witnessing the consent, as we have already said, is the most important thing. And though the physicians may not require to sign on that consent form, get into the habit of signing it. I've given you the reason why you should be the last person to sign that consent form so that you can see that the consent form is filled completely in details. And it proves that once your signature is there on the consent form along with the patient, it proves, because what does the law say? That the physician who is treating the patient should be the one to talk to the patient and explain everything to the patient. And that can be legally proved if your signature is also there on that consent form. So always get into the habit of signing that consent form. So what are the take-home message as far as I've tried to make, concise this talk so that you understand as, routine day-to-day practice what you should be doing. So remember that consent is a legal requirement which can be enforced by any civil court. And in civil court, we have the court also, you have the CPA, and you have the state councils which come, or it could be a criminal court. So mere signature on a consent form is no consent. So I have gone into details as far as what is informed consent is supposed to be, all the details which are there. Don't rush a patient into signing and consent. Try to take the consent a little bit in advance before doing that procedure. Medical professionals either ignore or are ignorant of the requirements of a valid consent. But in today's era and today's legal problems that we are facing, this has become very, very important. So instances where either consent was not taken or where an invalid consent was obtained have been a subject matter of judicial scrutiny in several medical malpractice cases which are seen. So thank you very much for the patient hearing, and I hope I've tried to, solve some of the problems as far as what do you mean by informed consent is concerned and how an informed consent has to be taken. So thank you very much. I'll stop sharing my slides.
Yeah. Thank you, Dr. Shivakumar Utre, for the wonderful presentation as usual. And I think the consent, specific consent, okay, is the most important. As you rightly said in Samara Kohli versus Prabha Manchand, now it is renamed as a real informed consent. This is one I want to. And most of the times, as I being an anesthesiologist, we take a procedure under the regional anesthesia, spinal anesthesia. Intraoperatively, we need to convert it to the general anesthesia. But you have taken a consent only for the regional and spinal anesthesia. So in such cases, where you are contemplating or anticipating conversion to the general anesthesia, that time patient is already anesthetized, so will not be able to take consent to shift on to the general anesthesia. In such cases, what I would suggest is, where such things are contemplated, where you anticipate, that time in the consent form you can mention that the anesthetist is authorized, okay, to convert from regional anesthesia to the general anesthesia. That consent can be taken, which you call it as a extended consent, as a composite consent, where it is contemplated. As you rightly said, any procedure, for example, you have done appendectomy, next day again you need to do a re-laparotomy or exploratory laparotomy for something else. That time does not mean that you have taken a consent, and we have to have a fresh consent, as you rightly said, with the documented case, Dr. Shailesh versus, I think, Aparna, something like that. And other one, what I'm trying to tell you is, most of the times we do forget, okay, to take a consent, and you authorize the nursing staff or whoever it is to take the consent. And taking consent is not advocated if the patient is already pre-medicated in the previous day. So if the risk of a complication is more than 10% or a relative complication, we should bring to the notice of the patients so and so is the risk of the procedures. These are the few of the things which I would like to add into this. The forum is open for everybody. If anybody has any queries, so they are most welcome. I also welcome Dr. Mahesh Sarode in this wonderful webinar. Over to Dr. Rajendra Prasad.
Thank you, sir.
Sir, can you share the consent form?
Yeah.
Yeah. See, as far
Consent
as the
form.
consent, no, as far as the consent form is concerned, as I said, the consent has to be procedure specific,
Yeah.
right?
There
So
is no
consent
universal,
any
there is no universally accepted consent form for any of the process. But I should appreciate, especially Foxy people, okay, they have come up with a few of the things and it is more valid. If any court of law, anybody questions about the consent form, they said that yes, this is recommended, this is accepted by our state body or the national body. So that is there in the Foxy. But other specialties, they have to come up with such kind of a procedure specific consent, so that which can be accepted in the court of law, because the organization is created and probably it has a more valid, they can appeal it.
Yeah, I think what I'll just add to what Dr. Kumar has said. When I was the president in Maharashtra Medical Council, I had written a letter to all the specialty organizations, giving the example of this Foxy. I think Foxy is the only organization who has got their consent forms for different procedures.
Yeah.
And the court of law always accepts, something akin to Boehm's test and all that.
Correct.
Once the organization says that this is the type of consent and you send it, which unfortunately Foxy has not sent it to the council, and the council endorses it, you are on very, very safe grounds, because there is a quasi-judicial body which has said that this consent form is valid, which even the courts will agree. So I think you should get behind your, specialty organizations to make these consent forms and get it endorsed by the state councils, which is very easy to get it done, so that you can use it all over, for all your patients. That is what I would suggest to all the organizations.
If any procedure is refused by the patient, the refusal consent should be documented. So, in a case, I still remember Dr. T.T. Thomas versus Srimati Elisa in Kerala, wherein the patient went into the acute appendicitis, and they did not do surgery because they did not give the valid consent. In the court of law, the court only asked him, why did you not document the refusal of the consent? That time, patient relatives said that, no, we were prepared to give a consent, but they never ever asked us. So in this case, so refusal of the consent is also equally important for taking the consent if at all refusal comes from the patient's end or the relative end. This one has to be taken care by the surgeons as well as the anesthesiologists. As you rightly said, consent for anesthesia should be a separate one, because surgeons may not be understanding the implications or the risks what the anesthetist anticipate, which has to be brought to the notice of this thing. One more thing, what I bring to the notice of all the members is, many times we do take untable death consent or grave risk consent. So I think Dr. Utre also agree with me. There is nothing like a death and consent table consent or else a grave risk consent. They all become like a ASA guidelines. Okay, we call it as a anesthesia risk stratification, grade 1, grade 2, grade 3, grade 4. So grave risk, something like that, or high risk, is the part of the high risk component, where the mortality is almost double than the routine procedures. So we have to take a high risk consent. And there is nothing like, most of the times we are reluctant to give anesthesia, and the surgeons automatically comes and say that, no, we have taken a death on table consent and we had to proceed with the anesthesia. So that time I used to give earlier, now I have declined to give anesthesia for that, because none can give a consent to die on the table with or without knowledge. So that I would say that the death on consent is a misnomer, and do not add to that. I think Dr. Utre can highlight into this.
Yeah, I think high risk consent is valid.
Yeah.
Because a patient who's got some comorbidities, you require to explain to him and the relatives all the possible risks which are there. What do you mean by high risk consent? That means you have spoken to him in detail as far as his comorbidity is concerned and how that can be affected when you're doing either giving anesthesia or you're doing the surgery. So high risk consent, and I think in anesthesia especially, you have defined what is high risk according to the gradations. So if the patient has got comorbidities, please take an high risk consent.
Correct.
Because tomorrow, if anything happens in a court of law, you can be definitely saved. I think death on table consent is something which should not be taking also, because if you are so sure that patient is going to die, why do you want to go and do it? So you are converting an act of omission into an act of commission, which is much more punishable. So
Correct.
don't take a death on table, but
Yeah.
definitely take a high risk consent as far as the patient is concerned.
Yeah. Okay. Anybody has any questions? Dr. Rajendra Prasad, you can appeal to
Dr.
other
Ma-
members also.
Dr. Mayur, sir, you can
Yes, sir.
ask your questions.
Yes, thank you, sir. Thank you, Shivkumar Kumbar, sir, for arranging nice session. And Uttare, sir, brilliant talk, sir. We are learning since last 10 years about importance of consent and documentation. And sir, sir always present very important point, and his lecture means I am attending since last 10 years, sir. Every lecture has some important points and take-home messages. Uttare, sir, my one question regarding recently I got a medical legal case from orthopedic surgeon that he actually is a conventional orthopedic surgeon. He did a total joint replacement, total knee replacement, and after that some complication happened. So he went for second opinion, and the other orthopedic surgeon told him that why the previous orthopedic surgeon haven't asked to go with a joint this navigation based or robotic joint replacement. So in our consent, whether it is important to mention all the recent advances, because sir, recent advances are always coming by every yearly. So it's very difficult to include all those recent advances in our consent. So, and if a surgeon is comfortable with the conventional one, so how can such consent to be taken?
No, see, basically, whenever you're taking consent, what are the principles of taking a consent is concerned? So suppose you are doing a procedure which is an accepted standardized procedure which is mentioned in the books.
Yeah.
And as I said, Boehm's test is most important over here, which courts have been doing it for years now. That if your colleagues can vouch that this procedure is also a standard, see, there may be multiple ways that you can treat the patient. Yes, when you're talking to a patient, suppose I'm doing an appendectomy, I can tell the patient, open appendectomy, there is laparoscopic appendectomy. So all that choice I have to give to that patient. If that patient wants to get it done by a laparoscopic method, and I am not a laparoscopic surgeon, I have no right to continue with the treatment as an open surgery. But if the patient consents that I want to get it done only by you, by this open method, but that consent should be there. So you don't require to, put the nitty-gritty things of all new things, because many new things may be there in the journals, but they are not there in the medical books also.
Correct.
So it's not necessary. What the courts look at is what is given in the medical books, not in the journals, because in a journal, it is the individual opinion of that surgeon who is doing that particular procedure, which he is put forward in the journal. The next step is that after the peer review and everything, and if it is universally accepted, then it comes into a medical book. So if it is there mentioned in the medical book that you can do it in an open method, definitely you are on safe grounds. But you should always tell the patients, as I told in my slides, that alternative treatment should also be told to the patient.
Correct.
Then it is the right of the patient to choose what alternative treatment he wants to undergo. So you can always say that I, as a surgeon, am doing this, and this is the best as far as I am concerned and you are concerned, that I can make available to you, and the patient has consented, you can go ahead and do it. No problem.
Thank you, sir.
This is the big problem, I would say, what we classically call as medical jousting by our own colleagues.
Correct.
Yes, sir.
Encourage the patient to go against you in the court of law. So
Right.
never ever say that. Many a times my students ask me, sir, that if something wrong has happened to that patient, we are supposed to bring that also to the notice of that patient, because your treatment will differ from what treatment he has got before that. I tell them simple thing, and that is what I do. You can tell him that in that situation in which you had gone to that particular surgeon, he has treated you as per that situation, and that was the best treatment. But today's condition, your condition is so and so, for which you require a different type of treatment, which I am forwarding to you. This is how you can explain to that. You don't require to say, many a times a simple thing what you utter in that, you may do it sometimes inadvertently. Kis gade ne tumko treatment kiya hai?
Yeah.
And that's what the patients and the relatives catch upon. So be very careful, especially when a patient comes to you as a second opinion. Give your opinion, which is the best for that patient, but at the same time, try to protect your colleague also, who has also, he's a qualified person, who has done, unless of course he is unqualified, then that's a different issue altogether. But if a qualified person has done, don't say something that, as I said, medical jousting should never ever be done. Because today you may do it to someone, and tomorrow someone else may do it to you. When because any patient can get some complication, you have no control over that. And as I have put, when I talk about medical negligence, I say every complication is not negligence.
Correct.
Okay, so this is a sad part in our profession that is happening.
Yes, sir. Sir, I want to add, sir, in our orthopedics, we made a study. Number of litigations happened in last 10 years. So particularly in orthopedics, everything seen on X-ray. So 60% of litigation are because of other orthopedician making different comment. Why plate is used, why not nail is using, how long weight bearing allowed. So 60% is because of other orthopedicians remark which gone wrong in that case.
Yeah, I do agree with Dr. Sarvade. Any other questions? And one more thing, what I add to is, most of the times in the multi-specialty hospitals or single window hospitals, we tend to forget to take the procedural concerns, especially for ascitic tapping, LP, and central line and other things. So in one of the cases, I think probably many people may be knowing it, Gopal Krishna versus Mukesh Chowdhury, okay? Where the patient had a ascites, the ascites tapping was done, and ascite tapping analysis was normal. They wanted to take the omental biopsy, I think. Yeah, that time they did the laparoscopic omental biopsy, and the post-operative patient succumbed. That time, when they scrutinized, they had not even taken a consent for the ascites tapping, as well as the something like it, telling that it's a very short procedure and you want to take a omental biopsy. I think both surgeon and anesthetist for not taking the consent, taking it very lightly, and failed to take the procedural consent. Both of them in landed that they have been awarded a compensation also. So, any honorable members would like to add something or would like to?
Dr. Chandresh, you can ask your question.
Yeah, please go ahead.
Chandresh Parekh.
Sir, myself, Dr. Mahesh.
Yes, sir.
Can a staff nurse register the MLC, sir?
Pardon, come again.
Dr. Mahesh from Tumkur.
Yeah.
Can a staff nurse register the MLC?
No, means she's not treating. Now, how means she's registering an MLC against you, or I didn't understand that.
No, patient. We work in a 24/7. We don't have doctors in the night duty. We will be from 9 to 4:30, 5 o'clock maximum. After 5 o'clock, if any patient comes with MLC, can she register in the
No, sir.
MLC
No, sir.
register?
No.
It has to be from the RMP. It has to be from the RMP registered practitioner. So never ever delegate such kind of things to the staff. No, it's not acceptable, sir.
One of the person is a High Court advocate, came around 8 o'clock with some MLC case and is stressing, called me and stressing me, why can't you register like that?
Then you will have to go over there and register.
Yeah, you have to go over there and see.
And depend on the staff nurse. The staff nurse cannot examine and treat primarily a patient. She can follow your orders.
Yeah.
The vicarious responsibility is yours, even if she has made some mistake.
Okay, sir.
Yeah. Anybody?
Yes, sir.
Good evening, Dr. Dev.
Yes, sir. Hello.
Go ahead, Devegowda.
Yes, sir. Sir, it was very informative talk, sir. As an orthopedician, I have one question, sir. Because we do many amputations, from finger amputations to leg amputations. So there is a saying that if it is a leg below knee or something like that, minimum 2 orthopedician signature is required for the consent. Sir, how far it is like we have to handle this? Like it's a finger or toe or the leg?
No. You don't require 2 orthopedic surgeons. The only place where the second doctor has to sign, as I have said, is in an emergency where you cannot take the consent of the patient.
Okay, sir.
There it is always better to have another colleague of yours endorsing what you're doing is proper or not.
Correct.
But if it is a primary, the patient, as I've told you, which patients can give you consent, you don't require some other orthopedician. I think the only place where you require a second is in gynec, if I'm not mistaken.
Yes.
Require the second person also to sign.
Mid-trimester abortions.
Yeah. So in none of the other, because that is under a different law, different act.
Yes.
Okay. But second opinion signature is not required in any other case, unless it comes under that particular act, They have got different acts for different subjects.
Yes. Thank you, sir.
Hello, sir. Can I ask a question? Dr. Meenakshi Deshpande here.
Oh, nice
Utture
to hear
sir
from
and
you, Dr.
Kumar sir,
Meenakshi.
yes.
Yeah.
Yes, sir. That was a nice lecture. I heard only the remaining half of the lecture. But anyway, sir, I would like to ask one question is there are so many emergencies which are occurring. Many times at many places when I talk, I learn that blood transfusion consent is never taken as a separate consent. It is always taken with the high risk consent of any case. So do you advocate taking a blood transfusion consent separately with each and every consent of operation, operative consent or high risk management, whatever, even in ICU?
Yes, blood transfusion and not only separate consent, every bottle will require a separate consent. Remember, because in the consent, the number of that bottle, numbering and everything should also be ideally over there. Because tomorrow, if anything happens, there is a mishap, that is what will save you.
Yeah.
And not only that, you first, once that you have given that transfusion, don't get rid of that bottle immediately. Keep it for some time if there is any, reaction.
Untoward reaction.
So you require that bottle to be kept with you for some time. Get rid of it the next day once the patient is all right. And every bottle requires a different consent.
Now, if the patient is unconscious, okay, and
different.
Yeah, that time there is no need to take a consent.
That is different. That the onus is on you. Then
Yeah.
That is your, as a treating surgeon or treating doctor, that you have those rights you have got because you're saving the life of the patient.
Because it is life saving, yes.
Yeah. Sir, one more thing, especially in sterilization procedures, okay, and Minister of Health and Family Welfare, Government of India, they say that the consent for sterilization, the spouse signature is not required, only the patient who is but when it comes to the MCI or NMC, ours is a different state, but they say that it is desirable to have the spouse consent also when, I don't know how exactly, either way the patient can file a case against if it is the both things are taken. How do you balance it, Dr. Uttare?
Take the consent.
Yeah.
See, in today's world, you have to save your skin.
Yeah.
So you take the consent. It is as simple as that.
Okay.
I understand because, they come under 2 different acts.
Correct.
At times, our acts are old acts which are never, they don't rectify what is wrong in that act.
Okay.
The MCI Act has come before the Sterilization Act has come afterwards.
Okay.
And in that, to give the rights to that particular lady so that she does not depend on the husband.
Yeah.
To go under, a sterilization procedure, it has allowed that powers are given to her. But then, as you said, there has been cases where the husband has afterwards gone and fought with that doctor for not taking his consent for this sterilization.
Correct.
So if possible, try to take the signature so that you are on safe side. As I said, you don't require the relative signature on that consent form. Legally, only the patient's is important. But it is always better to take that form because, as I said, if tomorrow any mishap happens, then that relative is there who will always say, yes, the doctor has explained to us everything as far as the consent is concerned.
Yeah.
Yes, same is applicable for MTP also, sir.
Yes. Okay, anybody else? Any questions?
Yes, sir. One more question.
Please.
Sir, a patient comes to casualty alone. Is serious, but he needs life-saving procedure. Take, for example, a CPR or an intubation, but he doesn't give consent. He's conscious. So how to proceed?
Note it down.
Yeah.
If he's conscious, fully conscious,
He doesn't want.
As I said, even if the procedure that you have advised to that patient is a life-saving procedure, it is a right of the patient who is otherwise, all those criteria are followed, who can give the consent, and he says, I don't want to get it done, you cannot do it.
Patient's autonomy has to be
Even if the
respected.
patient is dying, we can't do it.
No, sir. Patient's autonomy has to be respected in such cases. But if the patient is unconscious, okay, at that time, like a doctor of emergency has a precedence, so we are not doing anything.
But
Anybody else?
If he's not willing for that, take his signature and get it countersigned by a third party who is over there.
Correct.
That would be better.
Anybody else?
Go ahead,
Yes, sir.
Dr.
Dr. Anuradha here, sir.
Anuradha?
Yes. With respect to the online consultation WhatsApp message that we type, kindly be very clear. We have a tendency to just write tablet vomilas for vomiting. So, and I think henceforth we'll have to take a paper, write, and then
Take a photograph.
Yeah.
Take a
photograph and
send
post it. Not type directly.
And not only that where you have written there is a prescription format also which has today been given by the National Medical Commission. So it should have your name, your number, council number and everything. So it should be the patient's name and sex and the weight of that patient also. So with all that, it should be a photograph and it should be sent.
That means you must be carrying the prescription with you wherever you go, whenever the patient asks any follow-up.
Madam, can you write a prescription to anybody on a sheet of paper? No.
No.
Can't.
You're not allowed.
So it should be in our prescription paper.
Yes, definitely. And one more thing, Dr. Uttara said, pre-printed forms, okay, consent forms are this thing in RG Stone case, okay. And in this case, a very funny judgment, okay. Pre-printed forms are not acceptable as a consent, but I think it is stayed in the Supreme Court. It's not that.
I spoke with the concerned person in that consumer who gave that judgment, because I know him personally also. I spoke with him.
Okay.
It is not that pre-printed. They didn't say that pre-printed. It was interpreted in a different way. As I told you, it should be a form where there should be blanks for all these risks which are there, procedures which are there, any alternative procedures are there. Nothing was there in that. So that is why they gave that judgment. And it is, as you said, it is challenged and it has stayed. It been stayed.
Yeah. Anybody else?
See, remember another thing I forgot to tell you. All my colleagues after my lecture, they tell me, "Arey, so many things you have told us to do. How is it physically possible to take such a consent?" I give them a simple example. Do you take a loan for your car or for your house or insurance? There is a big booklet which you sign. That means what? You're giving consent to all those things. So for the simple thing like that, if you are going to give multiple signatures, why can't you take multiple signatures from the patient if tomorrow that is going to save your skin? So don't take shortcuts. Please take a full consent. You can, have the printed forms also with, as I said, blanks which are there, which you just fill up. But please take a complete informed consent in today's era if you are going to do any procedure.
Yes, sir. If there are no more questions, I can go ahead with the vote of thanks. I thank our President, Dr. Veerabhadraya, and today's guest speaker, Dr. Shivkumar Uttare, and moderator, Dr. Shivkumar Kumbar, and the chairman of Public Health Subcommittee, that Dr. Pawan Kumar M, and our senior vice president, past Dr. Anuradha Paramesh, and our past president, Dr. Prahalad Kanchi, and our president-elect Harish Delanthabettu, Dr. Mahesh, Dr. Devegowda, Dr. Mayur Sayurode, Dr. Vinaya Srinivas, Dr. Subrata, Dr. Indira Doddabalapur, Dr. Meenakshi Deshapande, and Dr. Alka Kute, and all the dignitaries who attended this today's meeting. Thank you, sir. Thank you very much.
Thank you and good night.
Thank you, everyone. Okay, thank you.
Thank you very much.
Okay, Uttara sir, we'll meet you in Hyderabad.
Thank you.
Okay,
Sir,
take
before
care.
we close, we'll also remind everybody for the building fund and the discounted membership.
Yeah, thank you.
With the
Thank you, Anuradha.
permission.
Thank you, Anuradha.
Yes.